Dr. Hadley Wilson, Chair of the Board of Governors of the American College of Cardiology and also Interventional Cardiologist at Sanger Heart and Vascular Institute, Carolina's healthcare system. And I'm going to talk to you about the highlights from day one of the TCT. Three major studies really reached out and grabbed a lot of the participants on the first day. The first one I'm going to talk about is culprit shock, which may indeed have enough impact to change the guidelines. And essentially, the upshot of that study was that patients who had multi-vessel intervention at the time of presentation from STEMI with shock did worse than those who only had the culprit vessel treated with PCI and stenting. And currently, the guidelines suggest that you should have complete revascularization in shock patients who present after STEMI. And this study fairly strongly showed that that's not the case and that they would have more untoward outcomes by continuing to do further vessel PCI at that time. So that should be deferred to a later time, or if at all. But only culprit PCI should be done in patients with shock. And again, we may see a change in the guidelines from this study. The next one on the first day was the Excel Quality of Life trial that came out, 3-year follow-up data, which really showed that clinically those who, from a heart team approach, had left main stenting did just as well as those who had bypass surgery, the traditional standard way in the past for patients with left main to be treated, and that according to quality of life, the stented patients did just as well as the surgery patients after 3 years, with slightly less cost than the surgery patients. So overall equivalency at 3 years, favoring this as a very good therapy to be considered by the heart team, stenting versus bypass surgery in the most critical left main stenosis. The third trial from the first day was a little bit technical, the DK Crush trial, in which the outcome of that study suggested that 2 stents should be put into left main lesions and this so-called double crush technique to open up the side branch, usually the circumflex, as well as the left anterior descending and left main, and that those patients actually seemed to do better than ones who had single stenting and then provisional PCI if needed into the circumflex. Quite a bit of controversy about that as to whether or not the additional metal really could, in other studies, reproduce these same findings. So that's yet to be confirmed in further studies. So that's the upshot as I saw it from the first day, Monday, of the TCT here in Denver, 2017. On day 2 of the TCT here in Denver, 2017, several highlights. There was a grouping of the bioresorbable stent trials or scaffold trials, the Absorb studies, both at 3-year outcomes, 4-year outcomes, and also an additional 30-day outcome in the Absorb 4 in a randomized fashion versus the metallic DES. The upshot of these 3 trials, all presented as late breakers on day 2, were that the Absorb patients did do better if they had careful selection and careful preparation, stent sizing, and then post-dilatation. And they did better than previous bioresorbable scaffold patients in the past who did not have this attention to implantation detail. However, the overall upshot is the same as what we've seen where the bioresorbable scaffold Absorb has been recalled in Europe and is in very little use here in the U.S. currently, primarily because of the increased MACE of stent thrombosis, primarily more than 1%, short and long term, and also the concern of increased outcome events, including restenosis. So in total, for these 3 Absorb trials, a lot more needs to be done with the bioresorbable scaffold, and it remains to be seen if future development in this area will overcome these tough obstacles of stent thrombosis and increased major adverse cardiovascular events. The other major trial that came out, one of the major studies on day 2, was again a great TAVR trial, Partner 2A and SAPIEN 3, cost effectiveness of TAVR versus SAVR in the intermediate risk patients with aortic stenosis. And the upshot from Dr. David Cohen was that the TAVR patients in the intermediate risk group did remarkably just as well as the surgery patients with actual slightly less overall cost in the succeeding follow-up period. So that reaffirms that TAVR is a very acceptable alternative or procedure to be done in these aortic stenosis patients of intermediate risk, and that overall costs in the long run appear to be less than with surgery. So those are the highlights as I see it from day 2 of the TCT 2017 in Denver. So for day 3 here at TCT 17 in Denver, there were 2 major groupings as I see it in terms of the late-breaking clinical trials that were presented on day 3. One grouping would be around DAPT and shorter DAPT periods, and this was brought out by the results of the senior trial, the DAPT STEMI, and the reduced trial. And in each of those trials, it appeared that shorter periods of DAPT in uncomplicated patients who had no events, either after STEMI or with acute coronary syndrome, or even in the senior patients greater than 75, those that had shorter DAPT periods with no events prior to that time could actually have less than the 12 months that's recommended by the guidelines. So in fact, without going into the detail of the different studies, there were 3 and 6 month intervals of DAPT before discontinuation in the bioresorbable polymer group of stented patients, and this suggests that they can have an excellent outcome equal to or even better than bare metal stenting, and also into those who take longer periods of DAPT, as long as they have had an uncomplicated course up to that time. Now that doesn't mean that we should take home that now we can start letting our patients go off of dual antiplatelet therapy after 3 or 6 months. We still need further studies in this area to determine whether or not the guidelines of 12 months will be reduced over time. But again, it's very encouraging that with these new second, third generation stents that we can consider in the future that we may be having shorter periods of the dual antiplatelet therapy treatment, and also hopefully less bleeding events as well. The second major group of studies, and there were 5 in the mitral area, really following on the great successes that have happened in the last few years with TAVR, are devices to help with mitral valve disease, both mitral regurgitation and mitral degeneration. And these patients now, there were essentially 5 studies presented with different devices, including valve-in-valve and special devices to help reduce mitral regurgitation through reducing the annulus size, and finally even the Tendyne study, which actually looks at a new mitral valve product to replace the currently diseased valve through a percutaneous technique. All of these were favorable very early on. May take a lot longer to develop than TAVR, but very encouraging that this other major valve of the heart has some percutaneous solutions in the future. Thank you. So on the 4th day here of TCT here in Denver, 2017, 3 different studies, very important, I think perhaps to keep everyone's attention to the last day of the meeting. The first presentation was the PREVAIL 5-year outcomes from randomized trial of left atrial appendage closure versus medical therapy in patients with non-valvular atrial fibrillation. And basically this was a pooling of the data of the PREVAIL after 5 years as well as the PROTECT AF. And in short, it appeared that the Watchman device for left atrial appendage occlusion appears equal to Coumadin anticoagulation overall in the long term, particularly in those patients who are not long-term candidates for warfarin. Ischemic strokes were slightly higher in the Watchman group versus the Coumadin anticoagulation group. But again, this is something that can be discussed with the patients for decision-making as to whether or not they would want to continue long-term oral anticoagulation versus perhaps the Watchman device to be implanted with perhaps as much as a 1% increase in ischemic stroke over time. The second major study that was presented this morning was the ORBITA trial, and this was a randomized, very interesting sham-controlled trial of PCI in patients with coronary artery disease, and it was done in 5 centers in the United Kingdom. It took a long recruitment period of about 4 years, and only 200 patients overall were enrolled during that time, so highly selected group of about 1 patient per month per center. These were people that presented with angina and then presented in order to consider coronary angiography and PCI. And interestingly, these were well-treated patients on 2 and 3 drug therapy with long time to average angina on the treadmill at about 9 minutes. So this was a highly controlled, well-treated group, very compliant group, and not much in the way of angina, maybe once a month on the average for the patients through the study. Anyhow, they went through the trial and they were randomized to either have cath and then FFR, IFR, basically physiologic assessment, and determined by that, then they were randomized to PCI or medical therapy. And it was very highly controlled, blinded fashion where the patients, those in the cath lab, those on the discharge team, and so forth, were in general blinded to the therapy that the patient had. And very interestingly, the results were, in short, that there was some increase in time to angina in the PCI stented group compared to the medically treated group. It was about 16 seconds more. They were looking for more than 30 seconds or more to make it a positive study. So in that case, they didn't improve their time to angina enough to make it positive that PCI was superior to medical therapy. On the other hand, by the hard parameters, which were IFR, FFR, physiologic assessment, and dobutamine stress echo done following the procedure, there was significantly less ischemia in the PCI treated group, suggesting that long-term outcomes could be better in this group. So it may help alter our decision-making with our patients who have angina, that if they are very compliant with 2 and 3 drug therapy over time, that this may be a very viable alternative. But if they're having daily angina and they want to consider having PCI or stenting for relief of angina, which has really been the major claim of PCI ever since the Courage trial 10 years ago, then PCI is a very viable procedure that can be done to help these patients have improved quality of life. The last trial, which is actually ongoing right now in the presentation, was the FAME study, 2 to 3 year clinical and cost effectiveness outcome of FFR-guided PCI in patients with coronary artery disease. And essentially, it affirmed that FFR guidance, physiologic assessment, using that to determine which patients should have PCI versus those that should be treated medically, is borne out over a 3-year period of follow-up, and that it's a very excellent method to help determine which of our patients with chest pain, angina, and even coronary disease are going to be best benefited by having PCI versus medical therapy alone. So thank you very much. I hope you've enjoyed these upshots, highlights from the TCT 2017.